Hey everyone, so today's video is going to be on urinary elimination. So I'm going to touch up on kidneys. I'm going to go over some basic like diseases and complications and so on. I'm also going to go over a little bit about hypo and hypervolemia and some important tips and information that I want you guys to know in regards to the electrolytes. So it's gonna be mainly on the renal system and the urinary system in this video. So before I go ahead and speak about like the diseases and all the abnormals, I always start off by talking about pathophysiology a little bit so you guys kind of understand the normals before you understand the abnormals. So the kidneys do have different functions that you need to know. The kidneys actually do a lot of things. So they do regulate your blood pressure with the RAS system. The kidneys release and receive different types of hormones. They are basically the filter in your body. A lot of medications are metabolized as well in the kidneys. So every time you have an issue with the kidneys, you are going to see that the patient is going to have some type of either blood pressure problems, they're going to have fluid volume problems, toxicities, things like that. Because if your kidneys are the ones that basically filter out things, are the ones that help your blood pressure regulation, the ones that release bicarbonate for the basic part of your acid and base balance in your body. All of these things are going to be altered. So once the patient starts to have kidney problems, you're going to see a lot of these signs and symptoms having to be pertaining to what the normals of the kidney function is. For example, let's say that the patient has a low GFR, which is that their kidneys are not basically filtering out things that they're supposed to. What happens is that the patient is going to start building up fluids. So you're going to see that the patient is going to start gaining weight, their blood pressure is going to get high because there's going to be more fluid volume inside their body than it's supposed to because they're not excreting it. So a lot of these things go hand in hand. That's why it's very important for you guys to understand how the kidney functions on its own without any complications, so you understand when a patient does have a complication why these things are happening, and it kind of helps you understand the signs and symptoms and remember them when you're test taking. So the RAS system is basically with angiotensin and renin. So basically the kidneys are altered by the fluid volume. So if the kidneys see that you need more, um, they basically if they see that the blood pressure is low, they're gonna do what they have to do to increase the blood pressure and vice versa. The kidneys also work with the lungs. So if you guys do like acid base imbalances and stuff like that, you know that the kidneys release bicarbonate and then the lungs are the ones that release CO2. So your lungs are the ones that are kind of like with the acid part of the acid base balance, and the kidneys are your basic contents, which is like the bicarbonate. So your lungs and kidneys have to be like working hand in hand for your acid and base balance to basically be balanced out and into homeostasis. So I just wanted to add the hormones that the kidneys release and receive. The most important ones that you should know is the ones that the kidneys release, which is your renin, your erythropoietin, and your calcitrol. So your renin is the one that's part of your RAS for your blood pressure. Your erythropoietin is basically what stimulates your bone marrow to produce red blood cells. So if the body's bone marrow is not producing enough red blood cells and the hemoglobin is low, etc., your kidneys are going to release erythropoietin, which is going to go stimulate the bone marrow and say, hey, we need more red blood cells because, we're low in oxygen or we're low in hemoglobin, etc. And then calcitrol is basically like your vitamin D. So if you have like vitamin D deficiency, your kidneys are going to be able to release calcitrol. Okay, so apart from that, you want to know your complications in your renal system. I know that this is going to be mostly for like med search too, but it's so you guys have like a little bit of a basic information and knowledge about it, because you guys want to, since we're going to go over the kidney functions, we want to kind of like go over this. So there's three types of urinary tract complications. We have our pre-renal, intrarenal, and post-renal. This is basically telling you like where is the complication located. For example, if we have a pre-renal complication, that means that whatever complication is occurring, it's before the kidneys. Pre means before, renal means kidney, so before the kidneys. I always think about pre-renal as volume. Why? Because let's say that the patient is dehydrated. This is a pre-renal complication, because if the patient is dehydrated, that means that the kidneys are not going to get enough blood, or the enough blood flow to them for them to work properly. Okay, so as well as overhydration. So if the patient is hypervolemic, that's a pre-renal issue, because if the patient has a lot of fluids, it's going to add, I guess if you want to say like workload to the kidneys, so they're not going to be able to filter out regularly because they're going to be overworked. It's just like when your body, when your heart has too much blood and it's just overworking, and then it results into heart failure, because eventually overworking is going to tire out that muscle. Okay, so a pre-renal always has to do with volume. It's a complication that happens before the kidneys. Now an intrarenal complication means that the complication is inside the kidney. So for example, glomerulus nephritis, I think that's how you say it, but it's basically when the glomerulus is not working properly, it's inflamed, infected. Kidney infections, for example, all of these things are intrarenal complications. Why? Because it's inside the actual kidney. So the issue is here inside the kidney. Either the kidney's not working properly, there's an infection going on inside the kidney, but it's an intrarenal because the problem is inside the kidney. Now, post-renal means after the kidney. So any complication that is after the kidney is a post-renal complication. Usually, I always think about post-renal as an obstruction. Why? Because usually it is an obstruction, like for example, like a kidney stone, a congenital problem, anything that happens in the ureters, in the bladder, or the urethra. Anything that happens here, any complication that happens after the kidney is called a post-renal complication. Okay, so make sure that you guys keep that in mind, and you understand it, because you guys are gonna touch it. You guys are gonna talk about it again in MedSearch too. So you do need to know these foundations, these like the foundation of pre, intra, and post-renal. So when you guys understand what to expect in the patient, you kind of know what's going on. Okay, so when we're assessing the kidneys, we're looking at different things to see what the patient has. So we have lab tests and we have diagnostic procedures, of course. For the lab tests, we're looking at the creatinine, the BUN, the GFR, the urine analysis, to see what is happening, if the kidneys is good, if the kidneys is not working properly, or if there's anything abnormal. Now, one thing that I want you guys to jot down and keep in mind, that creatinine and BUN, yes, they tell you the kidney function, but they're actually not the same thing. Okay, I want you guys to know that creatinine is basically your number one that tells you if the kidney is functioning correctly or not. It's your kidney function. Okay, now when you're assessing the BUN has to do with the volume in the body, meaning that if the patient is hyper or hypovolemic, so if they have high fluids or low fluids and not normal fluids, the BUN is going to be altered. So the BUN is altered by fluid volume in the body, whereas creatinine isn't. So the creatinine is going to tell you the kidney function, but it's not going to be altered by if the patient is dehydrated or if they're overhydrated. it's going to be the same number no matter if they are or not, because it's telling you the kidney function. It's not altered by volume of the blood or the fluids in the body. Okay, that's something that I didn't know at the beginning, and it wasn't explained to me well. And once it was explained, then it made sense. So just make sure that you know that bun is altered by volume, whereas creatinine is not. Okay. When we do the urine analysis, we're kind of looking for any abnormality, like if there's any ketones, if we see red blood cells, hematuria, infection. We could check if the patient has been on certain medications. We could check if the patient has glucose in the urine. We look at the color, the consistency, the odor. From the urine analysis, we could get a lot of things. Okay, we just have to make sure that the patient performs the clean catch, which is basically for females. It's a little bit more complicated because the males just have to urinate a little bit in the toilet and then pee the amount that they're supposed to. For females, it's the one that they usually test you on. You want to make sure that you tell the patient that they have to clean themselves first from front to back. Then they're going to pee a little bit in the toilet, and then that's when they're going to start catching the urine up to whatever line or whatever the nurse or whoever tells them to. Okay, then for the renal diagnostic procedures, these are basically done after the lab exams. This is like to confirm that there's no abnormalities. So usually the KUBs are the ones that are done if the patient has like maybe like that they think that the patient has like a calculi or something like that. They'll do an X-ray, which is the KUB. The only thing is that the patient cannot be pregnant, as well as CT scans. Patients cannot be pregnant because it does have radiation. So patients that are pregnant will have to do like an ultrasound or possibly an MRI. Now, we do have an X-ray that's called a pyelogram that has IV contrast, as well as a CT scan could be done with IV contrast. So every time that you're doing IV contrast, you want to make sure that you assess for allergies, especially for iodine. Usually when a patient doesn't know if they're allergic to iodine, you want to ask them if they eat seafood, shellfish, if they eat mangoes, and if they do they have any reactions to it. You also want to assess them for asthma. If they tell you that they're asthmatic, you want to ask them if they're dependent on a inhaler, because some patients are asthmatic and they're not dependent on inhalers. They just say that they have asthma and they really only had like one case of it or whatever. Sorry. And then we also have the MRI and the ultrasound. It's usually these exams are usually done when like necessary, like if the patient has cancer, if we see like a mass or a cyst or something like that, then we'll use the ultrasound and MRI. But usually for the kidneys, the most common diagnostic procedures that we do are the X-rays and then the CT scans. All right, so now we're going to talk about the infections that we could see in the urinary and renal system. So we do have a lower part, like a lower, basically UTIs, which is your urinary tract infection, could happen in the lower part of the urinary tract, or it could happen in the upper. Okay, usually when a patient has recurrent UTIs or they don't get treated and things like that, you're going to see that the patient has pyelonephritis, which is inflammation of the actual kidney pelvis inside. So in this case, pyelonephritis is going to be an intrauterine complication. Why? Because it's inside the kidney. Okay. So these UTI could be located in the ureter, the bladder, urethra, prostate, in the actual kidneys. I'm sorry, I'm yawning so much. I'm so sorry. I'm so tired. And then usually, most likely, the cause is E. coli, but of course, it could happen because of different things. Okay, so the risk factors are very important to know. You don't have to memorize these. They're kind of like, it kind of like makes sense after you think about it. Especially if you're a girl, you would know that like we're prone to getting UTIs for like the littlest things. So if you want to memorize them, you could think about hard to avoid, which is like the acronym that you want to learn. But basically, it's like basic things. Hormonal changes. Remember that women, especially, we have like a natural flora in like our vagina and stuff. So when hormones start to change, when we're on birth control, when we're pregnant, when we are on antibiotics, these hormones are kind of like altered, and then it could kind of like damage that flora in the sense, and then it could cause infection, especially if the patient is not using proper hygiene. But even if they are, there is still a risk that they could get a UTI. Okay. Also, antibiotics, like I said, antibiotics also change your normal flora. Renal stones. Renal stones are very prone to causing UTI. Why? Because it's a little, it could be a big stone. So it basically a stone traveling through your urinary tract and kind of like causing um your skin inside and your ureters and all that stuff to kind of like get scratched while it's moving. And then apart from that, it does get stuck in different locations, so it prevents your urine from exiting out. And if you know that urine being stationed for a very long time causes infection, well, the kidney stones are going to cause urine to be stationed, and then it's going to cause UTIs. Diabetes is also another issue for UTI. Also, toiletries like tampons, bubble baths, powder, and perfumes that girls put under there. These things, not only do they damage your flora, but like tampons are very, very bad. Not only because it's inside, but then like a lot of girls just don't change them when they're supposed to, and they leave it for the whole entire day. Just think about all that infection that's building up in there. So yes, it's going to cause UTIs. Bubble baths, of course, because of the stationed water, and then if you don't clean the bathtub periodically, then the I guess the bacteria and stuff that you go into the shower every day to clean off, it's gonna stay in the bathtub. So once you do the bubble baths, not only is the bacteria there, but you're filling it up with water that's stationed there for a period of time, and then you're going inside, and it just goes directly in there. For the males, BPH, the reason why is because the prostate enlarges. This causes stationed urine in the bladder, and then it's going to cause a UTI. Whenever a patient also has like a reflux in their urine, that their urine is backing up into the kidneys, that's another reason for infection, because anything that has to do with stationed urine or backflow of urine has to do with UTI. That's why I'm telling you that you guys don't really have to memorize this. It's all common sense. If you know what could cause a UTI, it's basically easy to answer when you're answering questions. Okay, an overextended bladder as well. Why? The bladder is not being empty completely. What happens when the bladder is not empty completely? You're stationary. You have stationed urine. What happens with stationed urine? Buildup of bacteria causes UTI. Okay, so if you see everything goes literally hand in hand, and it goes back to stationed urine, which leads to UTI. Okay, invasive procedures like indwelling catheters, very, very high in UTI, especially if the nurse does not use septic procedures. Okay, this is why when you guys do your validations and stuff, they teach you how important sterile technique is, because you're inserting something straight into the patient's bladder, and if you're not doing sterile procedure, you're basically inserting all that bacteria that you just got from the hospital bed and everywhere, and just inserting it inside. Okay, also having an indwelling catheter for a long period of time could also cause UTIs. And then a decreased immune system, of course, because they're prone to, getting any viral or bacterial infection. Now, the signs and symptoms of UTIs are very, very common. It's usually that the patient starts to have pain when they're going to urinate. They have to urinate frequently. they have a bad odor, they even have cramping, and they could possibly even have fever and increased white blood cells because of the infection and the inflammation. And then you do have to make sure that you assess your older patients, because when patients, like especially the elderly, they go into like this delirium stage, and it's not only with the UTIs, but every time that they have infection or sickness, they could go into delirium, and people are going to think that it's like pertaining to dementia or Alzheimer's or just old age, but it's not. It has to do because the patient is literally going into like an infection, and it's altering their mental state, and it's causing them to have confusion. Okay, so usually once they are treated, that confusion, that delirium goes away. So when you're diagnosing a patient for a UTI, you always want to get their history, especially ruling out STIs, because some of the STIs are going to have the same signs and symptoms as UTIs. So you always want to have a good history on the patient. You want to ask them if they've ever had UTIs before. You want to check to see, because a lot of patients are prone to getting UTIs, and then this is very important to know because, like I said before, UTIs could lead to pyelonephritis and kidney infection, and it's not a good route to go. And pyelonephritis and kidney infections consecutively can cause kidney damage, and then eventually like low GFR, etc. So after you do your history, you want to do the urine analysis, which we already spoke about. We spoke about the clean catch and what you're supposed to do. You're gonna do a urine culture as well. The reason why we do urine cultures is because you are not going to be starting an antibiotic on these patients until you get a urine culture and you know which antibiotic you have to give this patient. This is because remember that antibiotics start to get really resistant in your body, and especially in a patient that has UTIs for a long period of time or consecutive UTIs, if you put them on the same antibiotics every single time, obviously their body is going to or like the bacteria is going to know how to fight off that antibiotic, and it's not going to work. Okay, so every time you do a UTI, you find a patient with a UTI, you're always going to do a urine culture, because most likely you're not going to put them on the same antibiotics. Okay, and then you're also going to check renal function, like this the creatinine and the bun and things like that, your GFR, just to see how the kidneys are functioning throughout this whole entire situation. So you want to assess the signs and symptoms for the patient. Maintaining fluid status is very important, and monitoring the input and output. You want to make sure that you're controlling the patient's pain. You're educating. So all those risk factors that we talked about, that's what you're going to be educating the patient. These are some. This is where your professors are going to start getting questions from, because they want to make sure that you know the risk factors. And if you know the risk factors, then you're going to be able to basically teach your patient. The biggest thing about being a nurse is that we're educators, and we have to educate our patients how to prevent things. So if you know that your patient is taking bubble baths, you want to tell them like, hey, look, you're having UTIs and you're telling me that you're doing bubble baths, and one of the risk factors for UTIs is bubble baths. Maybe these patients don't know this, so you do have to educate these patients on these things, especially if they're getting recurrent UTIs, because you want to educate them like, hey, recurrent UTIs is not good, because eventually it's going to lead to worse infections of your kidneys, which is going to lead to eventually kidney damage. And once the kidneys start to get damaged, there's no turning back. Okay, once your GFR starts lowering and lowering and lowering, there's no going back. There's no way to bring up the GFR again. Usually it's just trying to maintain it at that state and not dropping it even more. Okay, so you want to make sure that you educate these patients about that. So when you guys are taking your exams and you find a question that it's educating your patient in regards to the UTI, make sure that you remember those risk factors, okay? Because then that will guide you to the correct answer, okay? We already talked about the labs. Urinary catheters are very high risk, but if the patient doesn't need one, then we will remove it. We could also have them do warm sit baths and heating pads for the pain. And then we always want to encourage the patient to avoid every 3 to 4 hours to not station urine, okay? Because remember that if they continuously hold their bladder for more than this time, they're going to station urine, and then that will give them risk factors for UTIs. We already talked about antibiotics. There is a medication that I want you guys to know, which is phenazopyridine. Sorry. Um, Usually, when they test you guys on these questions, they're going to um, test you on education for these patients. So you want to make sure that this medication, it's basically given for bladder spasms. But one of the things that you want to educate your patient is that their urine might be orange, and it's normal, because the first time that the patient pees, and if they see orange urine and you didn't educate them, they're going to freak out and go crazy. Okay? So it's very important that if you know that a medication is going to do something, you want to educate the patient so they know when to call the provider and when not to call the provider. Okay? You want to educate them on voiding after and before intercourse, avoiding bubble baths, avoiding tampons, and changing their pads often and not leaving them like the whole day. You want to advise them to try to avoid or at least reduce alcohol and caffeine consumption. Loose cotton underwear is very important, because underwear that it's not cotton could cause UTIs as well, especially if they're using non-cotton underwear and then wearing tight clothes at the same time. No wearing any perfumes or those sprays that they say that it's good to spray there. No, it's not. It damages your flora, so no irritating scents or anything that could damage your flora. And then the patient should drink a lot of fluids, and cranberry juice is very, very important when a patient has a UTI and also when they have renal calculi. And then talking about renal calculi, we're going to go ahead and talk about renal calculi. So a renal calculi is going to have the patient experience similar signs and symptoms, but a lot of patients are going to have different ones. Some of the signs and symptoms it's going to be very intense. Other patients are just going to have a renal calculi and not experience that many signs and symptoms. So it all depends. It all depends also, as well as like how big the calculi is and etc. So usually the main sign and symptom is flank pain. Usually the flank pain is going to radiate to the abdomen, the scrotum, the testes, the vulva. Sometimes it even radiates down to the lower extremities. So the flank pain is usually one of like the high signs and symptoms that patients are going to have. They're also going to have frequency or dysuria, which is like painful urination. They could possibly have fever and increased white blood cells. They could have sweating. Their skin might be pale. They might have nausea and vomiting. And another sign and symptom that is very common is hematuria, which is red blood cells in the urine analysis, okay? Because of that kidney stone traveling down, it's basically like hurting the insides and causing red blood cells to, drain out in the urine. Now, for the diagnostic procedures, like we talked about, we're going to do the KUB. We could do an IVP. And then a CT or MRI, and then a renal ultrasound or cystoscopy. Usually they do a KUB, and then if they find something, they send the CT renal protocol, because the CT scan is going to basically measure the renal calculi to see if the patient is going to be able to excrete it on their own, or if they're going to have to do procedures to break it down, or even surgery. Okay, so it always all depends on it depends on how big that renal stone is, and then that's why you do these diagnostic procedures, to be able to visualize it. And kind of like what the CT does is that it kind of like measures it, and it'll tell you like, well, the CT scan won't tell you, but the radiologist will know and tell the doctor like, hey, they could excrete it or no. Okay, so once we do like the labs, we give them medications for pain. We want to make sure that we're straining every single urine. Now, when you guys are doing priority questions, I don't want you guys to get confused because this is something that's very confusing when it comes to renal calculi. Yes, straining every single time the patient goes to the bathroom and straining their urine is very important, but the priority is input and output. Okay, so if you have a priority setting and it's telling you what is the priority is taking input and output. You want to make sure that whatever the patient is drinking and receiving IV is the same output. Okay, because that means that if their output is not the same as their input, that means that the renal calculi is causing an obstruction, having it build up. This could lead to UTIs, infection, and stuff like that. Okay, so priority questions for renal calculi is input and output is your priority. Then it will be straining all the urine. Okay. You want to tell this patient to also ambulate as much as possible, so the renal calculi could kind of like excrete. Fluid intake is very, very important, just like cranberry juice, like we talked about. And then you want to assess like the patient's pain and the urinary pH as well. So a procedure that we have to use if the patient's renal calculi is very big and they're not going to be able to excrete it, and we don't want to do surgery either because this could help, is called the extracorporeal shockwave lithotripsy, known as the ESWL. Basically, what this does is that it kind of shocks the area wherever the renal calculi is, and it breaks it down in little pieces, and then the patient is going to be able to excrete it. Okay, so this is kind of like a step from surgery because you don't want to go into you don't want to have a patient go into a surgery when an ESWL can break down the renal calculi and then they could excrete it. Okay, but again, if the radiologist or the doctor doesn't feel as if the ESWL is going to work and the renal calculi is too big, or it's causing an obstruction, or it has already caused enough damage, then most likely they're gonna do a surgery. They might even put a stent, depending on the obstruction and stuff like that. So it all depends, but that's like the last resort. Okay. Now for urinary elimination, we're gonna talk about urinary incontinence. We're gonna go a little bit back to fundamentals because this is a fundamental topic. So if you guys are reviewing your notes and stuff, you do have to go back to your fundies in regards to urinary incontinence, read about that chapter, and make sure that you know the different types of incontinence. We have your stress, the urge, overflow, reflex. We have the functional and the total incontinence. Basically, this is when a patient has involuntary leakage of urine. So, for example, the stress one is like when a patient sneezes, let's say they pee themselves. When a patient is unable to get to the bathroom and they pee themselves, that's usually the urge because they literally can't hold themselves from going to the getting to the bathroom. So you guys want to kind of like touch up a little bit on those urinary incontinence. It's a matter of just learning what they are, and memorizing it and understanding, but make sure that you guys know about stress, urge, and the total incontinence. Those are usually like the main ones. Now, when a patient has incontinence issues, the nurse has to do certain things to help them with this. So, you want to teach your patient to start going to the bathroom every 3 to 4 hours. This is going to train their bladder that every 3 to 4 hours they have to go to the bathroom. You want to monitor their fluid intake as well because you want to make sure that whatever is coming in is going out. You want to tell them to decrease their fluids a few hours before bedtime so you could allow the patient to sleep and not have nocturia, which is basically having to get up in the middle of the night and going to urinate. Okay, you want to have the patient avoid caffeine and alcohol because these two things are going to cause you to go to the bathroom, especially beer and caffeine. They make you go to the bathroom every hour or even less, depending on how much the patient is drinking. And then Kegel exercises is very good for the bladder muscle to kind of like get it pumped up and working again. Because a lot of times the urine incontinence is due, it's because of that the bladder muscle not working properly. This could happen, urinary incontinence could happen like because of aging, because of different things, but also when patients go into surgery, analgesia and like analgesics and all those things could trigger these things, and you're gonna have to teach the patient to like bring that back, like that muscle, bring it back to working properly. That's why usually when a patient goes into surgery, they have like a Foley catheter, because the analgesia that they put and all of the general anesthesia and stuff, it's just basically going to like um, paralyze that bladder muscle. Okay, so like we see stomas for the colon and the GI tract, um, we also have stomas that are for the urinary system. They could also be temporary or they could also be permanent, just like the GI ones. So we have the continent patients and the incontinent patients. The continent patients are the ones that are able to control their elimination, but they're having issues. And then the incontinent ones are the ones that cannot control their urinary output, and literally they have uncontrolled elimination, that their pee just comes out. Okay, so with continent urinary diversions, basically they'll do the stoma for the patient, and the patient is going to be able to catheterize themselves, okay, through that opening. When a patient has incontinence urine, they're going to have a stoma that's going to have urine continuously being drained out of that ostomy, okay? So there's two different things. Your continent urinary diversion, the patient is actually catheterizing themselves, whereas the incontinent urinary diversion, the urine is coming out at any point in time, okay, just like a colostomy. Now, what you want to make sure that you consider is that the patient input and output is at least 30 milliliters per hour or more. You want to make sure that they're going to the bathroom every 3 to 4 hours, that they're not having any pain, that the patient is being able to use their pan. You want to just make sure that the patient is being able to use the restroom, okay? Now we're going to go over to like the fluid volume deficit and overload, and then I'll touch up a little bit on some electrolytes that I want to make sure that you guys know for like 100%. So I'm out of breath. So for fluid volume deficit, this is basically when your body is low in volume, okay? So when a patient is low in volume, they're going to be with different signs and symptoms. So think about it. If the patient doesn't have enough fluids in their body, they're going to become thirsty. They're going to have dry mucous membrane. They're going to show signs of dehydration, anorexia. They're going to have weight loss, oliguria, because the reason why is that the kidneys are going to start like saying like, whoa, 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 we don't have enough volume. So I can't start excreting volume, because then we're going to even go even lower in volume. So what the kidneys say, like, hold up, we need to start retaining fluids. So what it's going to do is that it's going to start retaining fluids, and the patient is not going to go to the bathroom, because what it's doing is that little bit of fluid that we have in the body, the kidneys are not going to allow it to go away, okay, because it's trying to balance out. The patient is also going to have clammy skin, poor skin turgor because of dehydration, dizziness, confusion, weakness, fatigue, all of these things. We think about it. If a patient is dehydrated, they have all of this. They have dizziness, they have confusion, because the patient is basically asking for fluids. It's in need of fluids, okay? They're gonna have tachycardia, a thready weak pulse, hypotension, of course, because there's no pressure in the body whatsoever, because there's no fluids traveling in the veins or in the arteries. They're gonna have tachypnea, and then they're also gonna have decreased capillary refill, because there's not enough perfusion going on in the body, okay? So the lab results, very important for you guys to know. So when we're looking at labs, we're going to look at the hematocrit and the hemoglobin. In this case, when the patient does not have enough volume in their body, their hematocrit is going to be high. This is because they're dehydrated, and their hemoglobin, their hematocrit, is going to be concentrated. That's why it's high, because normally it's dispersed in the fluid, and it's dispersed in there, but now there's barely any fluid. So what happens is that whatever is traveling inside your veins and arteries is most likely hematocrit and hemoglobin with little volume of fluid, so they're going to be increased. Okay, the serum osmolality is going to be increased because of dehydration. There's going to be increased protein, increased bun, increased electrolytes, increased glucose. All of these things are going to be increased because there's no fluid in there to disperse all of this. So what happens is that they don't clump together, but they're more concentrated now because there's no disbursement because of the little fluid that there is. Okay, the urine specific gravity is going to be increased above 1.030. Sodium is going to be increased because everything is going to be concentrated. Okay, so complications that could result if the patient is not treated is hypovolemic shock, because eventually the kidneys are not going to be able to retain the fluid that is needed. So the body is basically going to go into a shock. Okay, so to prevent this complication from occurring, what you have to do is basically give patients fluids. If the patient's electrolytes are normal, this is why it's very important to do labs. If the patient's electrolytes are normal, usually we're going to start them off on isotonic fluids. What happens with isotonic fluids is that the only thing that it does is that it alters volume. Okay, so it's basically just like your regular fluids in the body. Now, if you give hypo or hypertonic fluids, what it's going to do is going to imbalance your electrolytes. So that's why you're always going to do isotonic fluids unless a hypo or hypertonic fluid is needed, meaning if electrolytes are imbalanced, then it's when you're gonna see that the doctor's gonna order like a hypotonic fluid. But usually normal saline and things like that, those are the isotonic fluids that are going to be given when a patient has hypovolemia, okay, to prevent hypovolemic shock. Now for fluid volume excess, this is basically when the body has too much fluids in the body. So what are we going to see? We're going to see that the patient has a lot of water, a lot of sodium retention. We're going to see that the volume, that the patient is overhydrated, that we have decreased aldosterone. If the body tries to compensate, because remember that aldosterone is the one that keeps like the water. So you want to make sure that you're assessing your patient for like weight, input and output and stuff like that, because usually these patients are like in excess fluids. So you're going to see that the vital signs are going to be with bounding pulse now. It's not going to be a thready pulse now. Now it's going to be bounding because you have a lot of fluids. You have high blood pressure because of all that fluid is causing, I guess, like resistance in the arteries, and a lot of pressure because of how much it is. And then it's going to cause tachycardia, confusion as well, muscle weakness, tachypnea, dyspnea, crackles because of the fluid overload, the weight gain, ascites, which is like the stomach looking like a big ball, because of all of that fluid overload. Okay, so now the lab tests are going to be the opposite. Now the hematocrit and the hemoglobin and all of those things are going to be decreased because now there's so much fluid that these molecules are now dispersed so like throughout, that there's more fluids than the molecules. So now it's going to be very like diluted. Okay, so the serum osmolality is going to be decreased because everything is diluted. Electrolytes, the bun and the creatinine is going to be decreased, as well as specific gravity, because think about, everything is diluted now. Okay, your ABGs are going to show respiratory alkalosis because of the hyperventilation, the tachypnea. And then if the patient gets a chest x-ray, it's going to show pulmonary congestion because of that fluid buildup, the crackles that you're having, that stationed fluid in there. Okay, now we're gonna talk about electrolytes. So my tips for you guys for electrolytes is that it's basically a memorizing system. Um, so you're basically having to memorize things. I'm gonna touch up on the most important ones that you guys need to know about, and like the pointers that you guys need to know about. But again, you guys do have to sit down and study these on your own and memorize them. Okay. So for hypernatremia is increased sodium. One a thing that you need to know is your lab values. So sodium should be around 135 to 145. If it's less than 135, it's hypo. If it's more than 145, it's hyper. Okay? So hypernatremia is that it's above 145. And then you want to know kind of like what these electrolytes do in the body so you guys could kind of understand what is going on when they're high or low. So, sodium basically maintains extracellular fluids. So, basically, wherever sodium goes, water goes. Okay. So, the signs and symptoms when a patient has too much sodium, you could think about fried foods. So they're going to have fever and flushed skin, restlessness and agitation, increased fluid retention. Why? Because if sodium is increased in the extracellular fluid, then basically water is going to leave the cells and go into the extracellular space where the sodium is, which is going to increase fluid retention. You're going to have edema, extremely confused because of the edema, and then you're going to have decreased urine output because the water is going to want to stay with the sodium, and they're going to have dry mouth. Okay, so as a nurse, what you're going to do is restrict sodium intake, of course. So usually sodium is seen in anything that's canned, any frozen foods, hot dogs, lunch meats, all of those hams like prosciutto, all of those things that we love to eat, very high in sodium. The cup noodles, bacon, table salt, processed foods, all of those things are high in sodium, so the patient does have to try to eat less of that. You always want to put the patient closer to the nursing station because they do have an altered mental status, and they do have like confusion and agitation, especially if they're elderly, and you want them as close as possible to make sure that you're monitoring them. In this case, you're gonna either order well, not you, but the medication that the doctor's gonna order is either the isotonic or hypotonic fluid. So isotonic, like I told you guys, isotonic is not gonna do anything to the electrolytes. It's just gonna add fluid. Okay, so what it will do is basically dilute the sodium inside the bloodstream. Now, for hypotonic IV, what it's gonna do is that it's gonna drive the sodium inside the cell. Okay, so it's gonna basically like decrease the sodium in the labs and then put them back inside the cell. Okay, and then you want to educate the patient about like the diet and signs and symptoms. Now, when the patient is in hyponatremia, so low sodium, it's a little bit more severe because now they're prone for seizures, they're prone to being lethargic, loss of urine, less appetite, orthostatic hypotension, shallow respirations, but those are really like late signs, and spasms of muscles. Okay, so there's a few types of hyponatremia. You guys don't have to go into like crazy stuff and like learn them all, but there is hypovolemia with hyponatremia, meaning that the patient is low in fluids and also low in sodium. So these patients are going to be given hypertonic fluids, which what it does is that it drives sodium out of the cells into the extracellular fluid, and then basically it's going to bring the water in, helping the dehydration as well as increasing the sodium. Okay. For hypervolemic hyponatremia, they're going to restrict fluids because the patient has too much fluids, and then that's why the sodium is decreased because it's like too dispersed out and too diluted. So if you restrict the fluids, it's gonna kind of like balance out. You could either even give them diuretics so they could excrete that hypervolemia and that high fluids, and then the sodium will come back to normal. Okay, when a patient has the SIADH, we're also going to restrict fluids, and we're going to give them an antagonist to ADH, which is basically it's a hormone that keeps fluids like water retention. So basically we kind of like want to restrict the fluids so everything goes back to normal. When a patient has lithium, not has lithium, is taking lithium, you do have to check their sodium levels because low sodium levels is going to alter lithium. Okay, and it's very important that sodium levels are normalized when a patient is taking lithium. And when you guys do mental health, you guys are going to understand why. All right, and then if they are in low sodium, you want to increase their sodium, of course. Now, for low potassium, hypokalemia. This is very important. Potassium is very, very important. Potassium is most likely going to be on your exams. Okay? Potassium is key. It has to do with your heart. So, your potassium is lethal if it's low or high. Okay? Your potassium should be from 3.5 to 5.0 or 5.1, depending on whatever your book now says. Anything less than 2.5 is very dangerous, and above 5.1 is very dangerous. Like hyperkalemia is very, very dangerous. It could cause dysrhythmias. It could cause a lot of issues. So low or high, very lethal. Okay. So the signs and symptoms for high with low potassium, everything is low and slow. They're gonna have a weak pulse. They're gonna have orthostatic hypotension, decreased DTR, confusion, weakness, shallow breathing. The EKG signs and symptoms are very important when it comes to potassium, so make sure that you guys memorize those. Make sure that you know that in an EKG with the low potassium, you're gonna see a depressed ST segment. You're gonna see flat or inverted T waves, a prominent U wave. These are things that are going to be asked on your exam, so make sure that you guys know this, okay? Everything is depressed in the EKG when potassium is low. Another way that you want to remember low potassium signs and symptoms is remember the 7 L's. So lethargy, low shallow respirations, loss of urine, leg cramps, limping muscles, low blood pressure and heart rate. Everything is low and slow. These are the ECG effects. So you see that the normal kalemia, everything is normal. You have your PQRST. Now, when a patient has hypokalemia, you see that the ST segment is depressed. You see that there is a shallow T wave but a prominent U wave. These are things that are going to be shown on the EKG that is going to tell you like, hey, the patient has an ST depression. We have to check electrolytes. We need to check a potassium. Okay? So it's very important that you guys know your ECG effects of electrolytes because those are going to be most likely the ones that they ask you on exams. Okay? Now, for nursing interventions, basically we're going to have to replenish and give the potassium. So usually we want to monitor the EKG. We want to monitor the respiratory status. We want to watch out for patients that are on diuretics. If they are on diuretics, you want to tell the doctor like, hey, this patient has low potassium. If they're not on a potassium-sparing diuretic like spironolactone and they're on furosemide or loop diuretics or something, you do want to tell the doctor because if you continue giving them the diuretics, is going to continue on lowering the potassium. Okay. Usually every time that you check potassium, you want to also check magnesium because magnesium and potassium go hand in hand. So every time that the potassium goes low, magnesium goes low. So you want to supplement also magnesium. Okay. Also, for testing purposes, you want to know what foods are high in potassium because these are the foods that you're going to want the patient to be eating if they have high potassium. and the foods that they want to stop eating when they have high potassium. Okay, so potatoes and pork, oranges, tomatoes, avocado, strawberry, spinach, fish, mushroom, melons, like cantaloupe, carrots, raisins, and bananas. For testing, as far as I know, the main ones that they ask are tomatoes, avocados, strawberries, cantaloupe, bananas, and spinach. Okay? Make sure that you guys know those. For hyperkalemia, this is high blood potassium. So now we're gonna think about the acronym MURDER. We're gonna think about muscle weakness, urine production low or absent, early signs and symptoms of muscle twitching or cramps, decreased cardiac contractility, so weak pulse, low blood pressure, diarrhea. Then the ECGs. The EKG is gonna show a tall peak T wave, a flat P wave, and a wide QRS and prolonged PR interval. Okay, so now here you're looking at a wide QRS, which is very, very important to look out for, because your QRS is basically how long the ventricles are taking to contract and push out the blood out of your body. So towards the body, I'm sorry. So if your ventricles are taking a long time, this is not good. Perfusion is being delayed. Okay. If we have a flat P wave, that is not good because the signal is not being pushed from the SA node to the AV node. Okay. So you want to, as a nurse, you want to monitor the cardiac and respiratory status. You want to stop any IV potassium supplements that the patient is having, if there is any. Usually the drug of choice, you could actually use insulin if the patient I guess, not if they could tolerate it. Basically, what insulin does is that if you give insulin, it drives potassium inside the cell, but then you have to monitor the patient's blood glucose level, and then if it goes low, then you have to give them dextrose. So it's kind of complicated. Another medication that they give in the ER is Caxilate. So if you ever had a patient with Caxilate, you know that they're going to shit all day. They're going to have diarrhea every single day. Just literally like diarrhea streaming down their butt without them being able to hold them. So that's why ER, like every time that the ER nurses tell someone like, hey, we gave Caxilate, whatever nurse is getting that patient, they're gonna have a very long poop day ahead of them, especially depending on how many doses they've given of Caxilate. So what happens with Caxilate is basically that the patient is going to be giving that medication and they're basically pooping out all that potassium. Okay, so every time that you're giving medications to decrease potassium, you're always monitoring it because you don't want it to go low, okay, lower than it's supposed to. So you always have to keep a balance. And then lastly, I think this is the last one that I wanted to go over with, is hypocalcemia. It's low calcium. So think about cramps. The patient is going to have confusion, reflex hyperactivity, arrhythmias, muscle spasms, and then the most important one. This is very, very important for you guys to know. These are the ones that are going to be tested on. Positive Trousseau and Chivostek's sign. So the Trousseau is basically you're going to put a blood pressure cuff on a patient and you're going to inflate it. And if their fingers come together, that's a positive test. So make sure that you guys check like a little video or like a picture of what I'm talking about. That's a positive test, meaning that the patient has low calcium. The Chivostek is like you're going to stroke the cheek area, and if it starts twitching, that's a positive sign as well, meaning that there's low calcium. So those two are very, very important for you to know because those are the ones that they kind of pinpoint on your exams. And as far as nursing interventions, safety is key. You want to make sure that you're assessing the patient. Remember that calcium is very important for the bones. So if the patient is low in calcium, their bones are going to be fragile. They're going to be, at risk for fractures and things like that. So you want to make sure that safety is very important. That you're also administering calcium and vitamin D because vitamin D helps absorption of calcium. Okay, and then the foods that are high in calcium is yogurt, sardines, cheese, spinach, collard greens and broccoli, tofu, rhubarb, and milk. Okay, and that's basically it for the tutoring.